If you look at a patient that has clinical symptomologies and is diagnosed with probable Alzheimer's disease, the way you confirm this is at autopsy by confirming that they actually had amyloid beta plaques and tau tangles present in their brain. That's how you get a confirmation this person did in fact have Alzheimer's disease, right? So it's at death. But yes, you bring up a good point. There are cases of individuals that have amyloid beta plaques and are clinically fine. They don't develop clinical symptomologies. Why is that? I actually had this conversation this morning with one of my colleagues that runs a program that's really centered around physical activity for individuals that are over the age of 65. And what I was communicating to him is that depending on the cognitive resilience you have, right, which I'll define what that is, that can actually make certain individuals not be affected as much as individuals that have lower amounts of cognitive resilience. So what is cognitive resilience? It's essentially, think about it as use of your brain in capacities that kind of creates a buffer so these promopathies cannot really affect the cellular mechanisms and ultimately alter the behavior. So engaging in cognitive activities has actually been shown to be one of the mechanisms that can actually lead to protective effects, even in individuals that do show, for example, amyloid beta plaques. So the story is complex, right?
Yeah.
Because once again, if we look at autopsy and here in our local brain bank, we actually see there's some individuals that do develop amyloid and tau pathology, but are clinically okay.
Mhm.
So what we're trying to do with those cases is understand why is that? What changes in those cells do they have that made those neurons resilient, even though the pathologies were actually present?
Mhm. And to the extent that's true, I suppose that would imply that the buildup of these plaques, even in these resilient people that don't present with overt symptoms, that doesn't necessarily mean that the plaques are benign or not doing anything. They simply just might be sort of powering through any extra difficulty, cognitive difficulty these things are causing. It's not necessarily the case that these plaques are totally, just harmless.
Yeah, so there's definitely evidence in the literature if you look at some of the experiments done in cell models, animal models, showing that the amyloid beta plaques can in fact cause some form of toxicity, right? And can elicit inflammatory responses in the brain that can harm the neurons. But once again, the question is, are those given neurons that actually undergo this pathology or have presence of pathology extracellularly? Because the amyloid beta plaques, I just want to clarify, are typically found outside of the neurons,
Those
right?
are outside.
Whereas the neurofibrillary tau tangles are typically found internally inside the cell, right? So the idea is that it's possible that a neuron, with someone that does have amyloid beta pathology, might just have that resilience to resist any sort of interruption that's brought on by the amyloid beta plaque. And these are some of the studies that are currently ongoing. And that's why it's critically important for us to also examine individuals that reach a certain age and are clinically fine to understand why they were resilient and didn't develop aspects of clinical symptomology. Yeah.
Mhm. And I guess there's an issue of cause versus consequence here. Have you guys pinpointed in the field whether these tangles, these plaques, are these a consequence of something further upstream that's going wrong,
Mhm.
or are they the cause of the symptoms
Yeah.
of Alzheimer's?
That's a difficult question. There's a lot of controversy in the field, right? There's one side that believes that the amyloid beta plaques are causative of the clinical symptomology because what they highlight is that the amyloid beta plaques are usually the first proteinopathy that shows up in Alzheimer's disease. But then as you progress and down the different pathologies, you then typically get the tau pathology, right? And it's not really until the tau pathology is present that you really find signs of clinical symptomology. What
Mhm.
you also find there are synapses are lost, right? So synapses are, you can think about a space between two nearby neurons. They communicate chemically that way, right? And by communicating and strengthening those synapses, you're able to produce memories. You're able to engage in various behaviors. And so when those synapses are lost or are not properly functioning, those behaviors are essentially compromised. So if we talk about the trajectory, it is shown that amyloid typically does occur first, and then you typically have the synaptic loss and then the tau pathology. But it's not typically until the tau pathology is present where individuals do start showing signs of clinical symptoms. Yeah.
I see. I see. So the basic order of operations here seems to be that these these beta amyloid plaques outside the cells start to appear. At that
Mhm.
point, you may or may not have any symptoms that are detectable. Oftentimes, you won't even have symptoms, especially more resilient people. Later on, it tends to be that you get these tau protein tangles building up inside of cells. That's typically when you start to see the clinical manifestations of the cognitive issues that people have. So, sort of putting that all together, I've seen people sort of point to autopsy data and say, like, well, we have plenty of brains where they had all these beta amyloid plaques, but they didn't have Alzheimer's disease.